Two,
Fine.
2 seconds. Sorry.
Uh-oh.
Sorry.
Too
I
late.
lost
Yeah.
my camera. Wait a minute.
Oh,
Okay, hold on. Let me get myself together. Okay,
the
wait.
doctor
Are
is
you ready?
in.
Yes, we are. Oh my goodness. Hopefully we stay in with the weather because
I
something's
know. It looks
something's
like
a
it's
blowing and
storming.
something's a brewing.
Yeah.
Whew.
Yeah.
But what's really a blowing and a brewing is this conversation
Yes.
regarding GLP-1s and everything. But for us, especially GLP-1s and cancer and breast cancer. So we got to talk about it, Ricky. We got to talk
We have
about
to
it.
talk about it. And I saw Dr. Cleo's research. And I reached out to her and I said, "Can you explain this to me more?" So so she was so, awesome to come and talk to us all about it. But I think the GLP-1 stuff is only one, I don't know, like a smidgen of all the work that you're doing. So I would love
Hmm.
to start with that. And then you can talk about whatever you want, honey, because
I
you're
love it.
doing
Okay.
so many, many good things. And so I'm not even going you introduce yourself and tell who you are. Because
And your
Okay.
why.
yeah, and your wife,
My
because we're just
why.
fangirling here and we love it.
Oh, you're so
Mhm.
kind. You're so kind. Well, hi everybody. My name is Cleo Ryals. The way, if you ever wonder how to pronounce my last name, you ever forget, I always say Ryals, like clinical trials. So you'll never forget that now.
I love that.
I am a cancer outcomes researcher. I have been a cancer researcher for 18 years now. So I've been in this space, in the cancer related space for 18 years now, have worked across a bunch of different sectors, including education. So I was in academia for a while. I was a community health educator at one point in time, literally going, knocking on people's doors, teaching them about breast cancer education and awareness, showing people how to do breast self exams. And now I work in the tech industry. I work at the intersection of data science and oncology, supporting drug development and evidence, generating evidence to improve the types of drugs that we have available or can make available to patients with cancer. So that's a bit about me. But I mean, Ricky, how you came across my work and what I do is about a year ago, I decided to jump on social media. I've been off of social media for 13 years.
Really?
And
Wow.
yeah, 13 years. But I decided to come back on for a couple of reasons, and this is getting into my why. About 2 years ago, my mother-in-law was diagnosed with kidney cancer. And like I said, I've been a cancer researcher for several years now. I'm pretty well versed in this space. Have had the opportunity to connect with all kinds of folks. But when you have someone close to you get, become affected with cancer, it really changes everything. And so for me, it was like really walking alongside my mother-in-law in this during this process, also supporting my family, helping to answer questions. Like for my husband, this was his mom, helping to answer questions about, what can we expect? What types of questions should we ask? What does this mean in terms of reading the report from the doctor's office? Because I don't know, it's really funny.
Right.
I hear this all the time. Oftentimes patients get their results like in their EHR system. They get
Yeah,
their
on
results
my
before they have
chart.
a chance
On my
and
chart.
before they get to chat with their
Yeah.
doctors. So we're
Yeah.
seeing the results before they've had a chance to talk to the doctor, and they're asking, what does
Every
this
day.
mean? And so that really helped to put things into perspective for me. Like we're really fortunate, bless my mother-in-law is cancer free now, but I realized,
You got
Hmm.
that a lot of people go through this every day, and not everyone is, in a position to have a cancer researcher in their
Right.
family,
it.
or,
Right.
on their, on speed dial for them, or, someone with expertise in oncology. And when you hear cancer, it's so scary for a lot of folks.
Hmm.
It feels really heavy. And so I really looked at that experience with my mother-in-law as well. Okay, she's doing well. I was able to walk alongside her and our family in this. Now, like, what can I do to help others? And so I launched this platform with the sole goal of trying to make cancer information, cancer researcher accessible to the
Hmm.
masses. Make it accessible, easy to understand, make it approachable, really demystify it, and help address this fear with reliable, accurate information that people can really use. So that's my why, my
Hmm.
mission. So
I love that. And I think you hit on something because when you look at the sources, the places where people get their information,
Yes.
you know, number one, family and friends, or number
Mm-hmm.
two is probably because number one is TikTok, number two is family friends, three is Instagram, four is Google, five is if
Right.
they're Black church, six,
Right.
maybe your hospital website. But so much misinformation, especially regarding cancer treatment,
Yep.
diagnosis. I saw somebody post on Instagram just today about ivermectin and how,
Ivermectin.
and a patient asked me
Ivermectin
earlier
is
this
going
week
crazy, going
about
crazy.
ivermectin.
I've
And,
got a
and
post on ivermectin. I've got a
yep.
post on it and trying to address that. Yep.
Mhm. But we have to also, I think, meet people where they are and understand why they're
Absolutely.
asking for these things. And, one of the things we've been doing here at the farm is really trying to lean into, and even with Bexa, understanding why people gravitate toward
Absolutely.
misinformation, right? The folks who are, oh, mammograms are causing cancer and this and that. Like there's a reason why.
Yep.
And it's because there's a gap in
Absolutely.
accessible and reliable and relatable information from trusted advisors. Where are the
Yep.
trusted voices,
Right,
right? And we're
right.
talking over people's heads
Yep.
and they don't get it.
Yep.
Yeah.
Well, I think that, and I think we were talking about that one before we came on the air, why do people go to Dr. Google? Why are people going to these sources? And it's because they don't feel like they're getting what they need from their doctors.
Mm-hmm.
And then I think the when doctors don't spend enough time with you explaining something and you walk out misunderstanding it, then your trust is a little breached. Like,
Right.
does this person really care about me? This person
Right.
really not care. Does this person, they don't want to listen to me and answer my questions. So maybe they're really it's not a good thing. You know what I mean? And then
Right.
that's when you start to breach the trust and then they look for other sources, right? So they're going to go
Absolutely.
to what's
Yep.
comfortable. And so I think what's happening, at least in our space, is because they are getting that diagnosis on their
Mhm.
chart.
On my chart.
They,
Yep.
they don't have an appointment for 3 weeks. So then they start going around
Right.
Dr. Google, Dr.
Precisely.
Gemini, Dr. whatever.
Precisely.
And then they get all different information and they're totally confused. And thank God they find us. Not everybody, but whoever finds us. And so then they say, well, so-and-so said this, and Dr. Google said this. And then, so what does that mean? And so they
Yeah.
can, and then they
Absolutely.
start putting their personal information into AI. And I'm like, oh
Right.
my goodness, do not say I have this, because now that's on the internet. And so people understand when they start to ask the questions in the first person, I have this, help me, then their stuff is out there, right? So
Absolutely.
there's so much confusion that's what we do every day. So we
Absolutely.
can find or give them these real sources of information. That's what I feel like my job is, that knowledge is power. So I need to give you the right knowledge.
Right.
And if I
Mhm.
don't know it, I'm gonna call Mo. If I don't know it, I'm gonna call you now. I'm gonna call Dr.
Mhm.
I'm gonna call Dr.
Mhm.
Fidel. I'm gonna call Dr. Carol. I'm gonna call somebody that can help answer the question, because people are hungry for information and they just want to
Absolutely.
know what they should have been told in the first place
Right.
Or
by their
what they
doctor,
didn't hear,
or what
because
they
that's
didn't hear.
okay.
Exactly,
And
what
they'll
they
read
didn't hear.
something, they'll hear
Right,
something, read
right,
something, and they'll
right,
say, okay, but this
right,
was so and so's, my family
right,
member, my cousin, or
right,
I found this
Absolutely.
information.
right, right,
And so
right.
teasing through that
Yeah,
is the job and the
yeah,
responsibility of the clinician who's also documenting and also has 20 other people to see and also whatever.
Absolutely.
But we
yeah,
still have that obligation, I think, to help people truly understand what's going on. And like I tell patients, listen, it might be my 500th time saying it. It's your first time hearing it.
Right.
So
right,
that
right,
means I can't
right.
gloss over it. And I think that glossing over and that
Yeah, yeah,
dismissing, kind of
yeah, yeah.
minimizing it, oh, it's just a little whatever. We
Yeah.
don't mean harm, but we do harm, right?
Right.
But
Right.
we
Right.
do, we do, we do, we do.
Absolutely.
So I also love that your title is a cancer outcomes researcher,
Mm-hmm.
because it sounds like you're going to get shit done. I mean,
She
so,
is. She is getting shit
right. I
done.
mean, like, I think I love the concept of having an outcome that can be meaningful to somebody. And I think when
Yep.
you start thinking about doing clinical trials and doing research or whatever, I feel like, research people just go in the lab and they just do stuff. But, but what is the answer? What is
Mm-hmm.
the, and I just got asked to rate, and I won't tell my answers here, what I think of the various pharma companies that make breast cancer drugs. And I said, I kind of based my answer on whether I feel like you're trying to make breast cancer a chronic disease or whether you're trying to cure it.
Mm-hmm.
And
Mm.
it's based on my own sort of personal experience with these companies who are so supportive, and I'm so grateful for the support that we get from them. But I'm always asking the question. So what's the outcome? Where are we going? Where's Oz?
Hmm.
What are we trying to accomplish here with this drug, with this trial, with this information? So, you know what I mean? I think there are, it's a business. So how do you figure out what's going to make a difference in people's
Yep.
outcomes?
And it's
Yep.
a moving target.
It's a moving target. It is.
This is
It
not
is.
just one disease,
Yeah.
right?
Yeah.
But I
Yeah.
think looking
It's
at
not.
who's
There is no
really
answer.
answering and asking the important questions, who's
Right.
collaborating
Right.
together,
Right.
and like you said, who's moving the needle. And
Um,
this conversation, because Dr. Cleo, I want to
yeah.
circle back coming into your research. I would love for you to share maybe a little bit of the evolution of your research. You know what, I started out kind of doing this, and then I evolved into, because you're in a really interesting space right now
Yeah.
that it's exploding and it's so timely. But how did you get there?
Yeah. Yeah. Yeah.
Gosh, yeah. How did I get there? How did I get there with this particular study? So,
Yeah.
like I said, I've been in cancer research for several years now. And a lot of my work initially really focused on, and it still does today, leveraging large data sets to examine patterns of care, outcomes of care, our treatments that that are tested and deemed effective in clinical trials. Are they also effective in the real world? Are we seeing the same level of efficacy and safety in the general population that may have multiple chronic conditions, who weren't represented in the clinical trials, or in people and patients of color as well. So that's really where I started. And all of my work really focused largely on looking at variations in care, really around equity. So inequities in care with respect to race, ethnicity, both documenting inequities, but then also trying to understand what are the key drivers of inequities that we see as well, and particularly trying to identify those drivers that are modifiable. So when I say modifiable, what are the things that we can actually address to help close
Yeah.
that gap? So that's where
Yeah.
a lot of my work, originated when I was in academia as a professor. A lot of my research was in that space. And then, like I said, I left academia in 2021. I went into the tech industry, and that's where I am right now. I work in the area of what we call real world data, real world evidence in oncology. And, during this time, I will say this, there's so much happening in this space when we talk about real world data, real world evidence. I think there's
Mhm.
just so many opportunities here, and it's pretty incredible. But I was, in about a year and a half ago, I was just, watching all this news around like GLP-1s and what's happening here, right? Like, it's
Yeah.
seriously an
Rampant.
explosion. Everybody's using them. I think the
The Oprah
estimate,
factor. The Oprah factor.
right, right, right.
Yep.
And for me, as someone who, I was formally trained as a cancer outcomes researcher, health services researcher with a strong bent towards equity, the question that came to my mind was, who's accessing these treatments? If these treatments are associated with a reduction in weight, these treatments are
Mhm.
effective with respect to helping to address obesity, just all
Right.
kinds of cardiometabolic issues, right? And
Right.
we know that obesity, diabetes, these conditions are disproportionately
Right.
represented in communities of color and communities
Mhm.
of
Right. Right.
lower socioeconomic status and background. And if these treatments
Yep.
are less accessible for a variety of reasons, right? So insurance coverage is definitely one, the
Cost,
cost, there's
whatever.
the
Yeah.
cost,
Yeah.
all
Yeah.
of that,
Yeah.
right?
Yeah.
Then could the arrival and use of these drugs, could they potentially contribute to the exacerbation of inequities? So the worsening of
Mm.
inequities. If the communities that are most affected have less access. That was the first place that I started.
Mhm.
But then again, as a cancer researcher, I also know that obesity is a risk factor for many cancers. In
Mhm.
fact, there are
Yes.
13
Yep.
obesity related cancers, including breast cancer, right? So the next question I had was, okay, if these drugs are associated with a reduction in, weight, they're associated with weight loss, improvements with respect to cardiometabolic health, insulin, all of that, then what is their potential impact on cancer-related outcomes? What is their potential role in cancer prevention? Like these are the questions that I had. Again, also recognizing that people of color have a disproportionate burden of cancer as well. So that's really how I came into this space. It really
Mm.
started from a place of trying to understand the equity implications of this. And then it was from there, as I delved into the literature, I found that there was very little on this topic because, right, GLP-1s, they just
Right.
kind of exploded. And so,
Right. Yeah.
right,
Well, and look who got access to them, right? The people who could afford them
Yeah. So
first,
afford
first
them.
and
Right.
foremost,
right,
despite
right,
the indications, despite the clinical indications, because if that was the case, we would have got it first. We would have been first in line.
right,
But
right.
Well, and if you think about it, if they were really built for diabetes, how many Black diabetes patients were available to take this drug? And then why? How did Oprah find out about it? She didn't have diabetes. You know what I mean? Like I think that it was almost like a
Hollywood can,
secret. It was almost
yeah,
like
they've
a
known for
secret.
years,
Like
though.
why weren't people taking these drugs? Why weren't the people who needed these drugs for diabetes? And I looked up the numbers for how many Black people have diabetes. Like 58% are obese. Like the numbers are huge for Black people with diabetes. Forget cancer,
Mm-hmm.
right? And then
Hmm.
so these drugs were here. Who was not taking them? So I got your question, like, why weren't they taking them? And then how all of a sudden did Oprah get a hold of it to lose whatever 100 pounds or however many pounds she lost? Like, how'd
Yeah,
that happen overnight?
I
She
those
was
are
here and then she was at the Oscar skinny. Like, what happened? Right,
I mean,
right,
I can't, I can't answer. I don't have the answers to those questions, Ricky. I think these are some really important questions to ask regarding the access factor. These drugs were available, variations of them, right? There were variations now of these drugs, earlier forms. But in terms of who had access, why they had access, these are all great questions. I mean, I think ultimately what we've seen over time is that there is an insurance factor at play here. There is a cost factor at play here. There's
Yeah.
also definitely going to be an awareness piece around this too, right? As well. And I think even today, right, like there's still this layer of like a stigma. I mean, even as common as these drugs are, there is still
Hmm.
some degree of stigma associated with their use. Like I know some folks who use these treatments, and I applaud them for it. People within our community, within the Black community, who use them, but when they share that they use these drugs, it's kind of like on the hush hush. It's like,
Yep.
yeah, but
totally.
I'm using
We're supposed to pretend like diet and exercise is everything. And so all you see
right,
are the videos of people furiously
Right,
exercising. And all of a sudden they
right.
show up like this. And
right.
you're right. Because look at Serena Williams and so many of the
Yeah,
stars, they didn't want to admit it. Even Oprah, she got backlash from Weight Watchers,
right,
right?
right,
Because she used a medical weight loss aid.
right.
And I think you're right. It culturally, we do have we ostracize people who use medication. Like I
Yep.
have family
Right,
members with their insulin, and I want to do this the holistic,
Listen,
right?
right,
Whatever
right,
right,
that
right.
means to
I
people.
have so
right.
many people who told me, "Oh, I just lost 80 pounds because I gave up carbs or I started working out again."
Yeah,
Or,
colonoscopy if that's the case.
yeah, right, right. I know, but I mean, people, you're right. There is a stigma about it. Well, I guess there's still a stigma about weight. And so,
That,
right,
Yeah,
that,
right.
well,
that.
having it
That
and
stigma
losing
is
it.
there. And then it's exacerbated. Well, I just lost 80 pounds or 100 pounds or
Yeah.
whatever I lost.
Gain
And
weight, lose weight, we got a stigma either way.
right, right,
Exactly,
right.
exactly.
So,
And it's really unfortunate because, right, like we know, like obesity, excessive weight gain, that is not by accident, right? This is all a function of structural factors, there's systemic factors, access to healthy foods, access to
right,
um, also physical environments that enable and support.
Yeah.
exercise, say
How
all of
about
that.
stress? How about stress?
Stress, right? There's stress,
Mhm.
right? Because the cortisol, like all of that, like
Right.
the stress
Inflammation,
leads to
exactly.
increased cortisol that affects your
Yeah.
ability to
Yeah.
also lose weight, right? So
Yeah.
there are all these other factors at play.
Hair.
All
Don't put my hair out.
so it's all of this. It's all of these factors that are also at play. And so then when we then have this message, this internal message that we're telling, this story that we're telling ourselves, and we're implicitly telling one another, right?
Yep.
About like your weight, it's your fault. It's a
It's your
individual
fault.
responsibility. And
Yeah.
I just gotta do a little bit more of this. And yes, we
You
do
do
have
have
a responsibility, but having medication or something to support you in that is not that's not a bad necessarily a bad thing,
right.
right? It's not that. It's just sometimes we just need a little bit of extra help. It's like I tell some
Yeah.
folks sometimes we don't stigmatize people who wear glasses, right? Like we don't say squint harder, like so you can see better,
Right.
right? We don't do that, but this is part
Love
of the
it.
issue and the
I love
challenge
that
here
energy.
too is really changing that narrative. And I think culturally, that's really important too for us to do that
Yeah.
as well. So it's
Yeah.
multifactorial,
Yeah, it
Mhm.
really is. It really is. And I
Body
think
shaming in the Black
if you
community
can,
is real, though. It
huh?
is. The body shaming in and of the Black community is
And it's
very
both
real.
ways. It's both
And
ways too.
it is, but then the same people who will say, "Oh, those fat Black women will go out and do all sorts of things to get the booty and to mimic the figure and all." So it's like
Hmm.
there's a lot to unpack there about our
It is.
our
It is.
body image and how it's defined in society by others and by ourselves.
By ourselves
By
too.
ourselves, by looking
Absolutely.
in the mirror. But I think also, at some point it's bigger than just obesity. It's what are the health implications of being obese? High
Hmm.
blood pressure, all the heart attack risk. Like I think of
Yep.
Luther Vandross. How many times did he go up and down? And he died from his strokes.
Hmm.
So all of that stuff. I mean, if you can do something, when you have a headache, you
Right.
take a Tylenol.
That's right.
When you have this, you take some. When you have a cold, you take a cold pill. So if there's a way to help make yourself healthy with a
Right.
drug, why not use it? Right. And why is that shameful? If especially so and it's more than losing weight. It's almost like when you are obese, there's so many other things that are happening with your body potentially, whether it's sleep
Absolutely.
like me or high blood pressure or
Well,
high
pro-inflammatory conditions,
diabetes,
right? We got to talk about
inflammatory,
inflammation.
yeah, right.
Yep.
So all those things can be helped by this thing that's also going to maybe make you lose weight.
Absolutely. And I mean, when we talk about all these other factors, I think again that's also what drew me to exploring this topic in the context of cancer, because we know research has shown that chronic inflammation, there's research that
Yeah.
suggests that chronic inflammation can create this environment that supports both cancer development and cancer growth as well, right? So it's that piece too. And so when you have, this chronic inflammation going on, it can increase your likelihood of developing cancer. And like I said, there's a reason why we say there are 13
I know. What are
obesity
they? What are
related.
those? What are
Oh
those? I'm
gosh,
just
all of
curious.
them off the top of my head. Oh
And
gosh,
just
I
tell
don't have
me,
them all.
give me the top
Yeah,
five.
yeah. So we know that breast is one of them. Ovarian cancer is another one. Multiple myeloma is another one.
Really, really.
Multiple myeloma, colorectal cancer is another, kidney cancer is another
Mhm.
one as well. And like I
Yep.
said, there are 13 of them.
Yep.
But
Uterine, ovarian. I got a
uterine,
diagram
yeah,
over here. I was just at a conference, a breast surgery
sure.
conference, and we had a whole talk on this. But uterine, thyroid, ovarian,
Thyroid, yep,
yep, pancreatic,
yep,
stomach,
yep,
gallbladder, liver,
Yeah.
and
yep,
brain too. Who knew?
yep.
Didn't know
Brain
that.
too is another
Brain,
one. Brain is
really,
another one.
really.
Yep,
Yep, and
yep,
esophageal.
Wow,
yep,
wow,
yep.
wow.
A lot of those GI cancers, so the gastrointestinal cancers, so like you said, the esophageal
Pancreatic.
cancer,
Yeah.
all of those are,
Wait, two for some reason. Isn't that
yeah,
interesting?
yeah, yeah.
Wow. Oh, wow.
And you
Wow.
bring up you bring up the point about the uterine one, and I know this is breast. We're talking a bit about breast cancer, the work that I did presented at San Antonio Breast, but I think that one's also really interesting too, because again, Black women are more likely to, like, I think the estimate is like 2 times more likely to die of uterine cancer
Yep.
relative to their white counterparts. And we know that obesity is associated with worse not just their increased likelihood of developing, but also associated with worse
Worse
outcomes as
outcome.
well.
Wow.
So
Wow.
it's all of it, right? So it's increasing your risk, and then we see that it's also associated with worse outcomes as well for many of these cancers. So, like you said, Ricky, I mean, to me, and this is what's really been interesting, is like looking at, like I said, there's been limited research in this space, but there is some emerging research that has shown, like there was one study that looked across all of these obesity related cancers, and they looked at they used like a really large data set, and they looked at associations between GLP-1 use and risk of developing these obesity related cancers. And not surprising, they found that people who were using these GLP-1 medications had a lower risk of developing these 13 obesity
Wow.
related cancers.
Wow. 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 Wow.
So, I mean,
That's huge. I mean, to me, that's huge.
right,
If I could have
right.
prevented my cancer, you know what I mean?
I mean,
Yep.
potentially, right? Because these are, like I said, these are
There are other
observational studies.
factors, right? Yeah.
They're not clinical trials, right? There could be
Mhm.
other factors at play, but it's like the evidence that I continue to see coming out continues to point to that same conclusion, that there
Yeah.
seems to be some sort of risk reduction associated with using these drugs. And what remains unclear is like, is it the drug itself? Is it because the weight loss itself? Are there changes that are happening metabolically within you? Is it the
Right.
inflammation? So I think we're waiting for more research, definitely needs to come
Yeah.
out, like could be
Yeah.
conducted to
Yeah.
understand
Yeah.
like, what are the mechanisms underlying this. And I would even say, right, like understanding the mechanisms, but also understanding this across different
Different.
subpopulations.
Yeah. Are Black people different from white people?
Are right,
Right.
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 Are the
Exactly.
Combo. Right.
benefits? Are the
Yeah.
And
benefits the
Yeah.
same?
yeah.
Are we
Yeah.
seeing the
Yeah.
same
Yeah.
effects?
Yeah.
Right?
Yep.
Yeah.
And I think
Also,
understanding that correlation doesn't equal causation.
That's
And
right.
precisely
Right.
right.
Exactly.
what
Exactly.
does that mean for people? Because I
Right.
know that there was a JAMA study
Yeah.
coming out, right? That people with breast cancer and type 2 diabetes who use GLP-1s had like 91% lower mortality risk associated with it than people who were on insulin and metformin. And all of a sudden people are like, oh, I need to be on Ozempic instead of insulin or metformin. And we have to, what I love about Dr. Cleo, what you're doing is helping people understand that no, you don't need to go run and get off your insulin necessarily, but there's
Right.
a way to interpret this data because people take it and they do a snapshot and they're on TikTok and they run with it. And we got to be
Right.
careful.
Yeah.
Absolutely. Absolutely. Yeah,
But you're also seeing that data or that success with recurrence, right? I mean,
Yes.
with
so yeah, so like in the study that I presented at San Antonio Breast Cancer Symposium last December. So we looked across, it was like we looked at nearly 1 million patients, it was like 900 and something thousand patients. And we looked at GLP-1 evidence of GLP-1 use among these patients, and associations between GLP-1 use and something called ctDNA. And so
yeah,
ctDNA stands for circulating tumor DNA.
yeah,
And I like to use analogies. I like to use analogies because I think that analogies make things a bit makes things easier to understand and accessible and memorable. So the way you can think of ctDNA is like it's like tiny fragments of DNA coming off of the tumor, off of the cancer. So this is a way to kind of detect cancer through blood before it's actually visible on any type of scan, right?
Mhm.
So it's a way to detect it pretty early. It's one way that doctors are able to track, like if your cancer is responding to treatment. It's a way for them to also track has the cancer come back, so the recurrence as well. And so ctDNA has been linked to a higher risk of recurrence and also worse survival. Another way to
yeah,
put
yeah.
ctDNA, another way I like to think of it is like if you can think of cancer as like a pot of marinara sauce on the stove that's boiling on the stove, and
I
that's the
love a good
cancer,
food analogy.
right? And
Yeah.
then right, like there's you clean you already made the pasta, the marinara sauce, all of that. You put everything away, and then somebody comes into the kitchen. They don't necessarily know what you cooked, but they look at the stove and they can see little specks of sauce, little tiny specks of sauce. And they're
They
like, hold
know it's
on.
spaghetti night. They know it's spaghetti
And
night.
they can smell it. They're like, it's, oh, somebody made some spaghetti. Somebody made some
Yeah.
pasta. Somebody made some lasagna or something
Body
tonight.
somewhere. Yep.
There's
That
some sauce
that's
around here, right?
there's something. I may not see the pot of spaghetti, but I know something was cooking. So that's the way you can think about circulating tumor DNA.
I love
So
that.
that's
I love that description. That's way
yeah.
better. I love that. I'm using that, still on that.
Yeah, I love analogies. So what
Yeah.
we did in this study is we looked at associations between evidence of use of a GLP-1 and ctDNA positivity. So is it positive or negative? And positive or negative just means if it's positive, it's just any little amount of circulating tumor DNA is considered positive. It has to be 0 for it to be negative. And what we found was that GLP-1 use was associated with a lower likelihood of ctDNA positivity. Now, remember, I said ctDNA, being ctDNA positive is associated with a higher risk, a higher likelihood of recurrence. And so that is what we found here is that there is potentially, again, it's not that we showed that GLP-1 use is associated with low recurrence. That's not what we showed. What we showed was that GLP-1 use is associated with a lower likelihood of ctDNA positivity, which may be relevant for recurrence risk and survival. And so really what this study showed is that it provides an early signal of where we need to be potentially be exploring a bit more and further. And so I recommended we should, consider doing randomized trials, conducting randomized trials to answer and assess this question. But I think it's really striking, what we saw just from this study, and it's the only one that I've seen so far that's looked at this question.
No, I haven't seen anything else, and I was digging for it when I first saw your research. I was all over trying to Google for it. No, I think that's a really good thing though, in terms of like helping people understand, because a lot of people call us and say, what is ctDNA test? So now I have a good description of that, but you should get whatever. And so it does, indicate where there's cancer in your body or there's a risk for, so now, but if you know that there's a sort of a path to that with the GLP-1, why not? If it, it's almost like, why not take these drugs? The data I found too is that right now, 26.5% of Black adults with diabetes use GLP-1 injectables. So it's about a quarter of people with diabetes. I don't have a number overall. I couldn't find a number overall of how many people are using them, but
I'm sure it's higher. Yep.
I'm sure it's way higher, because those are the diabetes people who need it, right? But
precisely.
guys, I want to back up for a second because I see all these people who take metformin, right, for years. And we did a little work on diabetes a couple of years ago, but they take metformin. So by the time they've taken it for 20 years and now they're 45 or 50 or whatever, the Black people start to have symptoms like blindness, losing a limb, losing a toe, whatever. The white people are good. So to me, we haven't even done enough data on sort of the long-term effect of the number one diabetes drug and how it affects Black people. Like, why are Black people dying of diabetes in way bigger numbers than white people taking the same drug? What's wrong with that picture? Right? Which also, then that takes me to, should we be really looking at these GLP-1s and the impact on Black people versus white people?
I think serum levels, right? Looking at the actual levels that are absorbed and that are metabolized.
The dosing, everything.
Yep, the dosing, but also the metabolics of it, the metabolism. Okay. And I think, one of the things like we notice with PET scans, for example, in cancer, the GLP-1s can alter PET scan results. So making sure that we understand how we're evaluating things like the ctDNA and like what assays we're using and kind of we can get deeper into this. But you're right, Ricky, in that we shouldn't just assume that one, if it's good for white people, it's good for Black people, but also looking at those different metabolic pathways a little bit. And it's something
that those big words you just said to people.
Meaning how people metabolize or how things get broken down in our bodies.
Down your body.
Just like you eat something and you chew it up and you swallow it and you digest it, our bodies do that too. and our kidneys can help do that. Our livers can help do that. And so looking at how our body uses enzymes or fork and knife, with the food analogy, right? Fork and knife to break down different things that we ingest, whether it's chemotherapy and the drugs that go through our liver, because we know that ancestrally, and I'll say, I'm going to say that word, that there are differences in our liver enzymes between, for example, West Africans and folks who migrated, in the transatlantic slave trade. There's differences in the types of forks and knives that we use, steak knife versus butter knife, right? And it impacts how drugs are broken down through our systems. So we have a lot of work to do if people will do the work, right? If we can get the funding to do the work. And it's never been more important as we look at, you said 900,000 patients. So we're looking at large volumes of information, these large language models and things that are informing AI, but we have to make sure that they're validated on the right people, that we're training AI on the right folks.
Yep.
Don't even get me started on that. Don't even get me
Oh, we got to
started.
talk about that.
Don't even get me started.
How they clock the tea, right? We got to talk about that.
All right. Wow. We have Val Blackwell made a comment in the comments. She's one of our blessees that really supports us a lot and helps us with events and stuff. So I decided to have a lap band procedure, as I did not want the GLP-1 because I wasn't sure of the effect on a breast cancer patient, on a survivor. Val, you can text me if you want the answer, but when was that? And how much did you know about GLP-1s when you did that? And what kind of information were you given by your doctor to validate that was the right path to take, And frankly, how does that surgery work on Black people? I've seen it not always work. I mean, again, the Black thing.
Yeah.
Well, I mean, I think this, is it Val? Is that
Val?
Yeah. So I think it's I want to get to a key part of the question or the comment that you made, which is you chose the lap band procedure because you weren't sure about whether and how the GLP-1 might affect your cancer. I think your question is precisely why we need to do more research on this topic. It is that, to me, that is the $1 million question, right? It's how do these drugs affect patients with cancer, not just cancer, what type of cancer? And then we know even within cancers, right? Like even breast cancer, for example, there's different subtypes. Right. And it's like when I talk to I've talked to different oncologists about this, or I've spoken to patients as well who have shared, their conversations that they've had with their providers. It's pretty mixed. There's some providers who say it's okay to take these drugs, that they don't have any concerns about it. There's others who say they're not quite sure about it. And so it really is pretty mixed. And it's because, like I said, the evidence just, it's not as mature as it is for other areas, right? And so when I say mature, what I'm basically saying is that there's just limited information out there right now. And so when you have limited information, it creates uncertainty. We're not really sure what to recommend to patients right now. But again, what we're seeing, the early signals are suggesting that it may potentially have some benefit. So,
yeah.
Dr. Cleo, 6 months ago, when patients have been asking me about this for, a number of years now. Up until probably 6 months ago, I don't think I knew enough answers to say yay or nay, right? This is really emerging data. And I think in oncology, especially, we try to be careful because everything that is good for someone, that we perceive as good for someone, and I'll give you an example, longevity medications and peptides and other things. Like people are asking and looking and trying to live longer and healthier lives, but everything that's good for those things isn't necessarily good for cancer.
That's right.
Right. And so we didn't really know, and we didn't understand the mechanism. And it stands to reason that weight loss is a good thing, decreased inflammation, right? You get your A1C under control, all those things. It should have an effect on cancer, but we hadn't done the math yet.
Absolutely.
Yeah.
Absolutely. And we also don't have, right? We also don't have what we call long-term follow-up studies, right? So you
Right,
may,
right,
so typically what we want to do in
right,
research, we want to have studies that, data for 10, 20,
right,
several years
right.
out. And especially when we're talking about something like cancer, where recurrence can happen many
And
years
here's out.
later, right? It can happen many, many years later. We just don't have those data, that evidence yet. So yeah, it's really an emerging area. But again, I think because the use is it's so high, right? Like the I've
Yeah.
seen some estimates that are about like maybe a third as well, potentially of Black people who are using these drugs potentially,
Mhm.
because and we didn't talk about this, and I'm not necessarily trying to steer us in one direction or another, but there's GLP-1s, the actual FDA approved drugs, and then there's also folks, who are taking like these compounded versions as well, which
Talk
we don't,
about
that's
that.
not regulated. That's not regulated. That
What are those? Like just
Come on with it. Let's do it.
Yeah, I mean, these are really like these are the compounded GLP-1s. These are really, I mean, these are like your telehealth, for example, your telehealth type of companies that they will basically make it. They will provide, make and provide and ship out to you these GLP-1 medications. And there's been a lot of, or versions of the GLP-1 medication, the active ingredient. And there's been a lot of concern, coming out from, there's pharmaceutical company concerns, and people have thoughts about that, like why pharma might be concerned. But then also FDA as well. There's also been concerns about that, as well as among medical providers regarding the safety of these drugs, because they're not
right,
regulated. They're not
Yeah.
right.
regulated
And
the
they're
same
just
way.
probably a lot cheaper. They're a lot
Right, and
cheaper
but
or
that's the
easier access.
thing.
Yeah.
That's the thing, though, right? Because it's cheaper, right? And
And
we know
folks
that
couldn't
access
get
is
it.
an issue. And these
Folks
drugs are,
couldn't get it. I will
I'm
say
sorry.
the manufacturers actually ran out. Folks couldn't get it because
Okay,
And
too
that
many
was
people
right, the
people, yeah, the people with
shortages.
diabetes couldn't get it. The people who really need
indication.
it
That's
for
right. The
diabetes
people who
couldn't
needed
get it.
them.
Bingo.
Yep. So you
Well,
have this
I
Again, it's an
actually asked,
equity issue. An
I
equity
know,
issue right there.
I know. I actually asked my
precisely.
endocrinologist about it a couple weeks ago. I have no thyroid because I had my thyroid removed from, I had hyperthyroidism, Graves' disease from too much chemo or whatever. And I said, well, should I take a GLP-1? And she's like, well, I don't know, Ricky. Like, you should ask your
Mhm.
cardiologist. Have you asked your internal medicine doctor? And she really basically didn't want to take accountability for recommending it to me, which I thought was pretty funny.
Hmm.
But she's like, you should call your cardiologist or call your, internal medicine doctor because
Mhm.
she's actually white and Jewish. My other two doctors are black. She's like, go call the black doctors. She knows them and ask them what they think, which I thought was interesting that she didn't want to, I really felt like she didn't want to take accountability for making that decision for me or helping me with that decision.
Sure. And because she just didn't have the
She
data,
didn't know. She doesn't
and
know.
Right. So,
right.
yeah.
And the
And
data on
that,
people who don't have thyroids taking these, like, what's the end? You know what I mean? What's this?
right.
So you're in a unique category all unto yourself.
Absolutely.
Right.
Yeah. Yeah.
Absolutely.
But where do you think
Absolutely.
the science and the research needs to go? Like if wishes were fishes, what kind of trial would you design that help to address and answer the most important questions right now for this?
Yeah, so I definitely think that, conducting a study to look at among patients who, I think the first place to start is among patients who are actively being treated for cancer.
Mm-hmm.
Um, Understanding the role of these simultaneous use of these GLP-1 medications on efficacy of these drugs. That's the question that I have. So if you're taking, for example, you're on immunotherapy, let's say you have triple negative breast cancer,
Right. Right.
you're on immunotherapy. Taking a GLP-1 enhance or have no impact or lessen the effect of
Of the
these
chemo. Right.
of these treatments? That would be the first one that I'm really interested in conducting, like that type of study. There's been some interesting observational work looking at this in the context of lung cancer, and what they actually showed was that immunotherapy efficacy was enhanced
Yeah.
by simultaneous use of a GLP-1, but lung cancer biology versus what happens with breast cancer, I mean, these are two different areas. But because again, we just see so many people using these drugs, right? There's so many people using them. That is the key question that I have right now is, can patients safely take these drugs while they're receiving cancer treatment? And particularly, I think I mentioned immunotherapy is one, but also with respect to chemotherapy, as well as also endocrine therapy. And I especially mention these
Yeah.
because we know that
Yeah.
endocrine therapy, for example, is associated with weight gain, right?
Mhm.
It's associated with weight gain. So what
Yeah.
happens when you take a GLP-1 and you're taking endocrine therapy? Does
Mhm.
it impact the efficacy in any type of way?
Mhm.
Whether it's enhancing, doesn't do anything, or it lessens the effect. To me,
Right.
those trials answering these types of questions are top of
Are
mind,
critical,
Yeah.
critical.
top of mind for me in terms of the impact, direct impact on people living with cancer right now who are facing this disease.
I
So
think.
I just found a study the other day, and I actually wrote a LinkedIn article about it the other day, 2 days ago, and you know, we call ER positive breast cancer the good one because we have the most drugs, we have the most history with it. So basically, 63% of Black women with breast cancer have ER positive breast cancer, which is the majority, I mean, a huge
Mm-hmm.
number, right? But their mortality rate is 50% higher than white women. So what's happening there? They're taking the tamoxifen, they're having tamoxifen, they're having bad side effects, and they're
Yep.
stopping, right? And they're getting a recurrence 15 years later, 10 years later, 12 years later, 20 years later, and dying.
Yep.
So what's going
Yeah.
on there? So when you add like the fact that you're taking these drugs to not have a recurrence, and then you add a GLP-1, then what happens? Right.
Right. Precisely.
Right. So
Precisely.
it's really scary to say this is the right path. I mean, I no longer call ER positive the good breast cancer
Well,
because
and
we've
maybe
retired the triple
probably
negative.
never should have, to be honest with you. Like
I
that's,
know. Well, they're none of them are good. None of
you
them
know
are
what I
good.
mean?
None
But
of them are good.
we did
Yeah.
because it had
Yeah.
a
It had the
longer
most
term
options. Yeah.
overall,
Yeah.
outlook that was a little bit
And we
different.
had the
But
most
that's
drugs
my
for it.
question,
But
and that too, right? There was an oral therapy for it. My question around this is also not just related to cancer, but any clinical trial. So many people are on these. Like,
Yep.
how is it confounding clinical trial data in general across the board?
Yep.
And
yeah.
or is it excluding people from participating in those trials? Because I really think that it should not, but I also think that we should be looking at them as a separate, I don't know if that's a secondary endpoint or something, but like we need to
Yeah.
we need to be looking at this.
Yeah.
Absolutely. Yeah, no, that's the question that I have as well. And today I have not seen anything on this. I mean, I have this question. Are they being excluded from trials?
Right.
If they're not, then are they conducting like separate, what we call stratified analyses? So a
Mhm.
subgroup analysis where we're looking at, safety and efficacy questions, specifically within patients who are using these drugs. Because keep in mind, and I mean, some people, are aware of this, but for those who aren't, these drugs also have their own side effects too.
Right.
Oh
It's
yeah.
not like
Brittle
you
bones.
just
Where
take
people
a
are saying brittle bones in the
We'll talk
chat.
about them. Let's run them
Yeah.
down a little bit.
Yeah. What are they?
yeah. So I mean, there are a number of side effects in terms of just like pancreatitis is a potential, that's on the box for it. There's also concerns around also bone density as
Yeah.
well. So I
Mhm.
mean, there are a number of different types of.
Nausea. Yep.
Yep, nausea, of course, right. So the GI
Dehydration.
type of,
Nausea,
right,
tummy,
cramping,
yeah, upset tummy,
Which,
yeah.
when you think about clinical trials too, there are adverse reactions that are kind of stratified as to how bad they are. How do you know that this isn't a result of, if it's a drug trial,
exactly.
essentially your
And I think
dehydration
people
and
start to lose
nausea.
their jaws.
Yeah, yeah, they use the buccal fat. That's true.
I
Yep.
don't know. All right.
Ozempic face, yeah.
Yeah.
Yeah, we had a question in
So,
the chat. Oh, sorry, go ahead, please.
oh no, no. I mean, so all I was saying was just that I think that this is something like, I'm not sure where FDA is in regards to their thinking around this, but I do think that that is something that we need to start
Yeah.
explicitly asking. This question as we're conducting this research, and we're evaluating these studies is, what proportion of these patients were on a GLP-1, and what were
Right.
the, what were the outcomes, the safety and the efficacy outcomes. And then if patients are excluded, right, based off of GLP-1s, which I think that is, I have concerns about that, again because of just
Yeah.
how ubiquitous, how common these drugs are, right? The real world
Mhm.
population that's ultimately going to use these drugs is likely going to include this patient group. So we should
Exact-
understand that in the context of a clinical trial, in the same way that we should also understand how these drugs perform in communities of color and, in women. I think it's the same logic here, but I haven't seen anything yet. We're not, maybe we just haven't caught up yet in
Right,
terms of
right,
asking these sorts of questions.
right, right.
Mhm.
Well, yeah, we have D,
Yeah.
D Cloud is out there. D is out there. Mo, she's saying,
Mm.
okay, wait a minute. As a breast cancer survivor, I want to know if the GLP-1 increases increases or reduces my risk of recurrence. It's so funny. She's saying, give me the answer.
It may reduce. Favor my answer is I favor toward reduction, and that's based on some of the data that was presented at the
Yeah,
Society of Breast Surgeons meeting not 2 weeks
yeah,
ago, maybe,
yeah,
right? With
yeah.
all the emerging data looking at GLP-1s and particularly breast cancer recurrence. So I think the data is favoring that. I did see her question also about the pets, and there's conflicting data on that. But the thought is that it might increase or it might decrease gastric emptying and cause more uptake in other tissues, right? Because your gastric emptying is slower. Your GI, your gut is slower. When you feel fuller, you eat less, things move through your system a lot slower. And so it could confound things like your PET scans. There's, like I said, conflicting data on that. You got to talk to your doctor about it if you're
Yeah,
on one,
yeah.
because the last thing you want is for uptake to show up in places, your heart, your muscle, your fat, etc.,
Right.
that aren't related to cancer. I think that's a really scary thing for somebody who's under surveillance, especially if you're getting
Mm-hmm.
and so ask those questions for sure. But I think the data is going to bear it out. And I think it's going to bear it out because we're seeing reductions in these sort of pro-inflammatory states in the body, right? And that has implications across all cancers.
Absolutely.
It has,
Absolutely.
our endocrine system is
Yeah,
altered by
yeah,
these things.
yeah,
And
Absolutely.
it's not
yeah,
just the
yeah,
weight itself, right?
yeah,
Because that's a
yeah.
problem too. When you look at people who lose weight but don't gain muscle, they're not healthier. They
That's
just have
right.
No,
less weight, but they
yeah,
still have too much adipose, too much fat.
Absolutely.
And so there's a lot to unpack here and talking about healthy lifestyles and really what type of weight loss we need to be doing, because people losing the pounds but keeping isn't is it's not the way to go either.
you got
Mm-hmm.
to do all the things. You got to do the workout. You got to do you move your body. I mean,
Absolutely.
at the end of
Yeah.
the day, we all have to just move our bodies. I mean, move your body.
And this can help. It can really,
It
you
can
get a little
help
bit of
you.
weight
It
off
can
Absolutely.
those
help you.
knees,
Yeah, but yeah,
right?
you
You
can,
feel like
yeah,
To
moving
make
yeah.
it
them.
easier. That's
You
right.
need to
That's
help you move
right.
your body. Yeah, those knees will
Yeah.
have less pressure on them yet. So,
Yeah.
gosh, 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 gosh.
Yeah.
All right,
Wow.
we have a couple minutes left. What else are you working on, girl? Like, what's next?
What
I want
is
to come in your
next?
house and sit in your lap.
What is next? What else do I have brewing right now? The questions that I have brewing right now. Gee, gosh, where do I begin? Huh.
In the meantime, though, we are going to try to work on some recruiting for some GLP-1 trials. I'm working
Great.
on it because I think we need more
Okay.
people in. So I'm working on that. I'm gonna call all my buddy pharma friends to say, let me help you recruit for
Hmm.
some GLP-1 trials. So I'll keep doing that. But
Yeah.
so many things to figure out for us, Black
Yeah.
people.
Absolutely. Absolutely. I mean, I think there's one area that I haven't necessarily started this yet, but one area that I am really interested in exploring, and I hope that I will have an opportunity to explore in the near future, is really looking at GLP-1s, their impact in the context of multiple myeloma. That is an
Mm.
area of interest, in large part because of the disproportionate burden of multiple myeloma in the Black community,
Yeah.
as well. And we know that multiple myeloma, for those who are not familiar with multiple myeloma, it's a blood cancer that is also one of the obesity related cancers that I mentioned before, a disproportionate burden in the Black community. And so I think there's a lot that can be unpacked there with respect to the potential impact of this treatment,
Yeah.
of GLP-1s in this context. So that's an area that I'm really interested in exploring.
I love that.
Um, yeah,
Good.
there's a lot that still needs to be done in that area in particular. And yeah, a lot of folks don't know about multiple myeloma, but it does disproportionately affect our community. And
It does.
so
It does. Yeah. And right now, really the best therapy is it's like a stem cell transplant, right? For multiple myeloma. I mean,
so there is stem cell, but there are also some other treatments as well that have come out, some different types of um, injectable, so
okay.
subcutaneous injectable treatment as well that have come out. And there's some others as well. There's also CAR
Mhm.
T. I don't know if,
Yeah. Yeah.
yeah, CAR T
Yep.
is also, and bispecifics. These are additional treatments as well that have come out that are proving to be very effective as well. Though it's in the case of CAR T, that's super expensive as well. That is very, very expensive. And so there's some challenges with respect to access to that. That's a whole other topic too. But yes, there are some newer treatments that have hit the market for multiple myeloma. But again, we still see that disproportionate burden within our community. So again, my question is, what can we address a little bit, outside of targeting the
Yeah.
cancer itself? What are some other things that we can address to help potentially improve patient outcomes as well? So.
Yeah, you change the environment, right? And everything changes. So much
Mhm.
to look at, even the mechanisms of these drugs, whether you're looking at the strict GLP-1 versus some of the others that are targeting two different systems, the
Well, what
Right,
tirzepatide.
exactly do they
right.
do? How do they work? I don't even know how they work. How do they work?
Doctor, well, if you want to speak to that, I'm not as well versed in how the different ones, the other ones work in terms of hitting the system, but I am aware of them.
They just make
It,
you lose your appetite and your
No, it blocks from the brain to the liver to a couple different mechanisms, right? So the whole way that the liver makes and metabolizes sugar, right? That gluconeogenesis pathway is altered. The gastric emptying is delayed. The brain and the hormone that signals us to be hungry, whether it's ghrelin, I believe is one of them, and I think leptin is the other,
Leptin,
right?
yep,
And so the hormones that tell us that it's time to eat or that we should be hungry, they get blocked. So it actually works on your brain
on your
too.
brain.
And
Okay.
so there's a couple different
That's physical
mechanisms,
and
like
mental, right?
the
So,
fat, the
yeah.
heart, the pancreas, yes, lots of different ways that these drugs end up targeting us. But yeah, you're right. It's not just by blocking your appetite or making you feel full. Like that's part of it. But the other part is it slows down how much the transit of your food and then it blocks your brain. Yeah.
I think that's pretty ingenious, frankly, because
that's the food
even if you think
noise.
that, yeah,
Yeah.
that's the food noise. I mean, if you think
Hmm.
about all the weight and I've been blessed. I've never really had to lose weight, so I don't really know the experience, but it seems like the struggle is there
Real.
and it's mental and physical, right?
Yeah.
So if this is a tackling both things, I sort of
It's
want
showing.
to take one to see what happens, but
It's showing also that it can help people who have addictions, right? So whether
Addictions,
it's
yep,
smoking, whether it's drug addictions,
yep,
et
really,
cetera,
that's
because it's altering the brain's desire to have and do things, right? So you call it the food
absolutely,
noise, right? But also probably other addictive noises that come in from whatever psychosocial and other feedback loops. But
absolutely.
yeah, it's so that's
interesting.
what's interesting to me is that people stop smoking. I'm like, listen, this could be the rising tide that floats all boats. If
I
we can get
know
my
this is
patient to
pretty phenomenal. This is pretty
lose some
phenomenal.
weight,
Absolutely.
right?
Lose
Get
some
that
weight and
A1C
stop
under
smoking. If
control,
we can get
stop
people to stop
smoking.
smoking, hello, lose weight and stop smoking, how cool would that be? I know one
But
of my
it's not a
daughter's
magic
friends.
pill.
Yeah.
And you follow the advice of your doctor. I have to say this because
Yeah,
we're
yeah.
on the internet,
Yeah,
using the web,
don't just go take
right?
this.
This is not
Just-
diagnosed. This is not intended to diagnose or treat
right.
anyone who's watching.
Right. Right. Right.
But get
Yeah.
involved in
Just
the
talk to your
trials
doctor.
too.
Just talk to your doctor. And
And
if you
get
don't
involved
like the
in the
doctor you're talking to, call us and we'll find you another doctor. But
yeah, and get in a trial, right? We need the
and
data.
get in
We
a
need the trials.
trial. Get in
Absolutely.
a trial. If
Yeah.
you can get in a
Absolutely.
trial,
Even
get
just
in a trial.
observation, right? Letting them
Yeah.
see how you're
Yeah.
doing and answering surveys. Like
Yeah.
it's not all drug
Yeah.
trials here. And I think that that's something people need to know. When we talk about clinical
Right.
trials, it's not all treatment and drug
Behavior.
trials and pharma
Absolutely.
experimenting
Yeah.
on you. These are drugs you might already be on.
Yeah.
Be
And we need
taking, absolutely.
to know what we're doing.
Yeah.
Observational studies. That's right. That's
Observational.
right.
So
Yeah. Yeah. Get in a trial.
we need you. If you're watching, we need you.
We need you to
Yeah.
be in a trial. Yeah. We'll try to help you find one. So, email me, Ricky at
Yeah.
touchfrequency.org. Wow. Dr. Cleo, you're a badass.
You are. I'm so glad I got to meet you because I do follow you and stalk you online. So,
I
you
Oh,
know.
know, if you
goodness.
are, how can other people watch you and follow you online?
Yeah,
Because she's dropping the pearls and the gems, I have to
yeah,
tell you,
yeah,
and
yeah,
breaking it down in really digestible ways. So, how can
yeah,
people follow
yeah.
you?
Yep. So you can follow me on Instagram. My handle is Dr. Cleo Ryals. And also stay tuned because I'm getting ready to launch a YouTube channel very soon where I will provide more long form videos. So basically the short what I share on Instagram, but in a longer format to really get into the details and answer some of the bring a little bit more clarity to some of the complexity on these different topics. So that is going to be look out for that coming out very soon in the summer, and I'll announce that
All right, we
on
need to
Instagram
talk. We
too.
need to talk. I have an opportunity for you, girl.
Okay.
Oh,
So your
Okay.
Instagram is Dr. Cleo Rouse.
Dr. Cleo Rouse.
I thought
there
so.
it
Yep.
is. I
Um,
love it.
putting it here in the comments. But I have a proposition for you. I'll call you about.
Okay. Sounds good.
Um,
Wow. We hope it's been relatable and reliable and real. It's what we do here every Wednesday night, and we are grateful.
yeah,
And we just, follow, follow, and share. You can always reach out to Ricky at Touch BBCA. You can follow me, Dr.
yeah.
Monique Gary, on all the social media platforms. And, stay tuned because I think this area of research is it's exploding and
It's exploding. It's
not
exploding.
without us,
This
right?
Absolutely.
Nothing
platform
about
is
us without
exploding.
us. Yeah.
Yeah. Can't do it
So,
without us. We gotta get in it. Get in it to win it.
yep. See you next week.
So see you next week. And I'll see you in Chicago.
We'll see you in
Yeah.
Chicago. All
See you in
right.
Chicago.
All right. Bless you,
Yes,
love.
we have to
Thank
meet
you,
up,
Mo.
Doc. Let's
I
make that a
know.
plan
Yeah.
I'd
already.
love that. I'd love that.
All right, I'm gonna
Absolutely.
Yeah.
hold you to it.
I'll work on that. Okay.
Oh, look at y'all with your
Love
hearts.
you.
That's so
We'll do it
I
sweet.
our
know.
I
heart.
This
love
is
that.
our bless you love. Bless you love.
Yeah. I don't know. Mine won't
Oh,
do it.
You
I
never know
love
when your
that.
hearts
Oh,
are going to come out. I know.
yours
Ricky's
is
is
actually producing something.
We don't know
Wow.
how
That
that
is so neat.
happens. We don't really know how
That
that
is so
happens.
neat.
yeah, you
Yeah.
gotta hold it
Oh,
long enough.
wow. Oh,
Yeah.
you got the magic over there.
I
That's what
don't
it
know.
is.
That's it.
All right. Blessings
Take
to you.
care.
Love you,
All
Mo.
right.
Thank you so
Okay.
much. Thank you so
See?
Thank
much.
you. Okay.
Thanks.
Bye.
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 Bye.